suite with the IR people.
Mm. Mm.
So we do most of those cancer ablations, tumor ablations that they've now started doing, the interventional radiologists.
Okay.
So that's what we are doing quite regularly. So we have lists for that.
Is it the private organization, hospital, or a government? Government.
It's a government hospital. Singapore government actually works on co-payment basis. So most people get government based. So they pay 20% co-pay, 80% the government pays,
Okay.
and
Okay.
that carries on everyone. And
Okay.
I think it's socialistic to a point, but 20% you have to pay. The best thing is that if you cannot pay, and if you have children, they make your children pay.
Oh,
So
ho, ho.
it's a very traditional sort of a society.
Right. Right. So,
Yeah.
do you have total private corporate hospitals there?
Yes. Yeah. Glen Eagles is here because
Mm.
Glen Eagles in Parkway now. They're in India also.
Mm-hmm.
So they're Malaysian trains and they are here
Mm.
and they do quite a good business. They had a very bad time during COVID, but the business has picked up again.
Okay. Okay. Mm.
And Singapore is known for its medical tourism, and it hasn't changed.
Yeah. Yeah.
It was pretty hard in the past 2 years, but it's going back to same actually. So
Very
well worth.
right.
Yeah.
So very good to hear about being done there. Quality work. Mm.
Yeah.
Oh.
It's just like because the government sets everything, they set all the standards,
Yeah.
and like you have I so we have a Singapore Society of Anesthetists as well, but
Mm-hmm.
they're not many. So we do courses every year. There's one conference that happens every year. We don't do webinars at all here.
Right. 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 Okay.
Yeah.
How many bedded hospital? Yours? How many bedded hospital?
1,000.
Oh, it's a huge one. Very huge. Yeah.
Actually, no. So we are one of the smaller hospitals.
Mm-hmm.
It has a population of 60 lakhs, and we've
Mm.
got about 8 hospitals. So the bigger ones are 2,500 bedded hospitals, to 2 or 3 of them that way.
Okay. Okay.
And because Singapore has got a lot of old population, so we now have community hospitals. So the government is making community hospitals and rehab hospitals specifically for older people in a way
Right.
to give hospital at home opportunities.
Good. Very good. Mm.
I think India also has to move the same way because India, the way population is increasing, I think
Mm.
20 years we also need a lot of community hospitals.
I came to know that critical care after Australia, Singapore is considered to be very good. Is it so, or in every aspect it's how you rate Singapore this quality and overall standards in the comparatively in the
Overall
world?
standards, yeah, I think overall it is quite good. They try to maintain standards because the Singapore hospitals are basically work on American standards. So the ACGME, the
Mm.
American Colleges for Graduate Medical Education, they come in and inspect every hospital, most hospitals.
Mm.
That's one part. Secondly, the Ministry of Health does a lot of checking in year after year. They
Right.
really have to maintain a huge amount of because they look at the quality assurance purposes very minutely. So if
Mm-hmm.
you fall down, then the hospitals get penalized.
Mm-hmm.
It's done quite well. I think the patient numbers may not be that great, but the
Mm.
work that they do, they like to keep it clean. So I think the ethics committees, every hospital has ethics committees, and they're actually independent authorities.
Right. 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 Okay.
Yeah. But I think India is also going the same way now. I think we have lots of quality assurance things going on.
Yes. 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 Absolutely.
Yeah.
No, the
Some
India.
of them,
We all know that India is a very big international center for all the. When people are coming from various countries to India, but
absolutely, health tourism is burgeoning. I think India will take a bigger step because health tourism in India is much cheaper. And I
Mm,
think centers in southern India are actually doing very well.
yes, 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 very good.
I say southern India, I think below Madhya Pradesh, everything is southern for northern Indian people, unfortunately. That
Mm,
is the joke that goes around, but I think in Hyderabad, Bangalore, there's huge hospitals who work really beautiful work.
Yeah. So South India, as you said, South India is comparatively in an entire country. South India and the patient, the quality and the hospital
Absolutely.
management, there is no comparison. Absolutely, day by day is growing very much.
Yeah. Absolutely.
Venkatesh?
That's what I've realized.
Venkatesh Rao.
Sir.
Sir Ramakrishna Adugo, shall we wait for some more time, or I think the first
if Preet and Priyanka are not in a hurry, we will Sudhaminga 23, 25. Okay, sir, we'll start. So who is doing first, Priyanka? Priyanka or Preet?
I will go first.
Okay.
I will go first.
Okay. So welcome to ISA Telangana webinar. This is 40th webinar we have been doing. So with the help of all the seniors and all the faculty, so very interesting topics sometimes, and very encouraging attendance also. So today's we have our president ISA Telangana, Dr. Ratnakar, with us, and Dr. Satyanarayana sir. He is the chairperson for today, and he was the past president of ISA Telangana. And Dr. Venkatesh Rao is the moderator for today's session. And we have invited two speakers who agreed readily when we requested. Dr. Preet Anand Singh, he's a senior consultant in Singapore, and Dr. Priyanka Bansal, who is associate professor at Rohtak, PGIMS. So I'm on behalf of ISA Telangana. Thanks to both of them. So I request Dr. Venkatesh Rao, our moderator, to take over the session. Thank you.
Sir, warm welcome to all participants. I think 30 participants came. So I welcome Dr. Preet Anand Singh sir and Priyanka madam.
Thank you, sir.
Loud.
The 40th webinar
Loud,
we are conducting from
loud. Venkateshwar, loud. Your voice is little low. Venkateshwar.
Okay. Yeah. Okay. Now. Okay.
Yeah.
This is the 40th webinar we are conducting since almost 1 year with our, as sir said, with our seniors, faculty, and everything. And also we are having today two important PG-oriented topics, which are very much interested in PG examination going people. So we are having our chairperson today, Dr. Satyanarayana sir, HOD professor from Southern Medical College. He's a retired professor from Osmania Medical College. He's our guru, and is more actually past president of ISA Telangana, and is very much good academician. Is you can say it's a godfather like for difficult intubations actually, and one lung ventilation management. So I am welcoming Dr. Satyanarayana sir to take over the session. Sir, please.
Yeah. So good evening, everyone. First of all, my sincere thanks to the both speakers, who seems to be very dynamic, very talented faculty. Today we have very good topics, and we know this ISA, webinar program, one of the prestigious academic program of Telangana state. So we have been doing, as the people said, it was the 40th webinar. We have been drafting many consultants, senior most consultants. They are reputed in their respective fields. So this particular webinar is very useful for both consultants as well as PGs. So today we have a highly talented two speakers, and one is all the way from Singapore. First of all, I thanks for accepting to be a part of this academic program, today's program, for both Priyanka Bansal and Preet Anand Singh. And the topics are very interesting topics. It will be very useful for both practitioners, consultants, as well as the PGs. The first speaker, one topic by Preet Anand Singh is about hip surgery, GA versus regional. So he is going to enlighten us options based on various factors. So ultimately, he is going to tell us his experience and all. First of all, let me have his a few credentials about his FRCA and MSc Pain Management, Senior Consultant in Department of Anesthesia and Director General Anesthesia Pain Service, Changi Hospital, Singapore. Is also an assistant professor, Duke, NUS Medical School, Singapore, and Honorary Secretary, Pain Association. And areas of interest is very, great to know, but he is so much talented. Ultrasound guided pain and regional anesthesia, point of care ultrasound, crisis resource management simulation, pre-hospital trauma, and very interesting is air evacuations courses. These are all highly credentials the Preet Anand Singh has got. At the same time, Priyanka, another reputed, very highly talented Priyanka Bansal, Associate Professor, Department of Anesthesia, PGIMS, Rohtak. And she is a ASS certified BLS, ACLS, BLS instructor. Many, to her credit, they have many international national publications, and she is an invited faculty for all reputed conferences like ISA, AORA, OA, ICCCM, and her special interest in anesthesia, regional anesthesia, post-operative management, and critical care. So with so much talented two speakers we have today, so I definitely it's going to be beneficial to all the many consultants and the speaker, the PG students. So welcome you all. The first speaker is going to be Preet Anand Singh is going to discuss about the hip surgery, GA versus spinal. Now over to Preet Anand Singh. Please go ahead with your presentation. Thank you. Preet Anand Singh.
Can you hear me?
Yeah, we are hearing.
Okay, Dhanyavad Ulu. That's the first thing for the introduction. And Shubha Sayantram. Good evening to all of you. I'm sorry, I'm a Punjabi by trade, as you know. So if you just came in and sitting on a chair, can you do that for a second for me? See if you can do this for me. Can you see this clearly?
Yeah.
Yes.
Okay. Are you able to do this?
Not possible.
Not possible. I would agree, not possible. Okay, so thank you very much from my side and from the department that I come from, because there's a lot of things that go on in our department. There's lots of data about GA versus spinal, what should we do, what shouldn't we do, and doses. So I'm just going to take you through some evidence. It might be a bit dry. Please stop me and ask me questions if you want to. I'm more than happy to answer. So there's not much to ask later if there are any problems. Okay. So there's no conflicts of interest. I've not broken any hips. I've not fixed any hips. I just do simple general anesthetics or spinal anesthetics. I'm still work in progress, as my wife used to tell me. And the various images, they've been cited. I will give you QR codes that you can click from your smartphones that will show you the articles I'm talking about. And I will give you a list of QR codes at the end for the articles which are free to see. Okay. So we'll start with, should I do a GA or a spinal for a hip fracture? I think it's talking about what's better, Apple or Android. We all have our views, but I think they both sell. That's what I want to say right at the beginning, that we are talking about Apple v Android. No one wins in this race, unfortunately. We do what we feel is better for us. Okay, that's the objectives. I'll talk through. And there are some recommendations from the American Academy of Orthopedic Surgeons and also from the Association of Anesthetists in the UK. We'll talk about. Okay, first thing, as Simon Sinek, if you read his books, start with why. Why are we talking about it? let's be very clear, hip fractures in an older patient are a devastating injuries. You see people who've had hip fracture, a year down the line, there's almost a mortality of about 25%. The 75% who survive, more than half of them can never go back to the same quality of life. So it's devastating for the people who suffer this injury. Second, for the people you see in hospital, you would find that the incidence of hip trauma, the amount of beds that the people occupy in various hospitals is more than any other trauma combined. So if you look at the trauma beds only for a hospital, about 58 to 60% of trauma beds are occupied by hip fracture patients, unfortunately. Okay. And it's not easy because the morbidity is quite high. These people, if not operated in time, will have lots of issues, including pneumonias, including venous thromboembolisms, myocardial infarctions, cognitive dysfunction. So that happens. Mortality is quite high. I said 10% of people won't really see past 1 month, and almost 25% die off within a year of having a hip fracture surgery. So we have to think what's going on, and there's a huge impact on the patients, on their relatives, and socially as well. They're not able to go out. So it's a huge impact on the whole thing. It's a financial burden on the patients. If you look at studies from away from India, they cost a lot of money, thousands of dollars every year to get the patient up and running, to get rehab, to get a new bed, to care for them. So things actually climb up one after the other. The other part is we as anesthetists, we don't have consistent pathways. If you look at the surgeons, more than 90% times they know what screw to use, where to use, and what surgeries are to be done. So we are still further away. Ours is a variable practice, and why that is because there are numerous guidelines you read. There are lots of studies that came out, Regain trial that came out in 2021. Then we had the Raga trial that came out later, talking about what's better, GA or spinal. So there's conflicting literature, and we're not to blame them. The issue is that based on large observational studies, not many RCTs, and even if there are systematic reviews and meta-analysis from which the guidelines come, they're mixed methods, heterogeneous population, and there's variation in anesthetic technique. I'll talk about it next slide. And also, we don't know what the outcomes that they look at. So if you look at why do I talk about variable anesthetic techniques? Some people just do spinal, okay? No sedation whatsoever. Sometimes use intrathecal opioids. In the same study, you'll find that people are using spinal with sedation, TCI propofol, opioids, ketamine, and depth of anesthesia is sometimes not told. So we're not sure what goes on. Is it a spinal plus a GA, or is it just what's going on, or combined spinal epidural? And sometimes there is light GA. I'm not sure what light GA is, but I think when the studies mix all these people together, finding what works better isn't going to be really possible. Okay? And last but not the least, there are people who do GA with nerve blocks, and that muddles up the story as well because the amount of drugs you need then are not clear. Okay, I'm sure that's confused us a bit. That's the reason that the guidelines are fairly confusing. Cochrane guideline, which came out in 2016, which looked through about 3,000 odd patients, they said they weren't very clear because they said the quality of evidence and the outcomes like mortality, pneumonia, etc., the difference wasn't there. And this has been replicated again and again. So I think there's also an issue with what outcomes they look at and how they manage these things. So saying that, I'll take you to Regain trial, which was published by Mark Newman from America. They looked through good 800 odd patients, and the whole idea was they were looking at regional versus GA for independence on patients at 60 days. So the patients are getting regional anesthesia, the other was getting general anesthesia, and they were seeing if there was any difference between the two sites in comparison to them being able to walk. So their outcomes were death at 60 days or the inability to walk is what their outcome was. And they found that there wasn't much difference. You gave spinal or GA. Now, I'll tear it apart a bit for what's gone on in this study, because this study gained a lot of traction from the media. And we actually had patients who came into us and said, look, we don't want spinal, we want GA, because this is published, and they say there's no difference. And sometimes that becomes a bit of a difficult time trying to dissuade the patient to say, you know, there are much more things other than just GA versus spinal and the outcomes. So they said spinal was not superior to GA. They also said the incidence of delirium and hospital lengths were same, and eventually came out saying that it's not just the anesthetic, but also the multidisciplinary team, orthogeriatric model of care, and the skilled specialist team. However, if you look at, like, these are the primary outcomes, you would find that the incidence of death wasn't very different. Inability to walk wasn't very different. Delirium and CM weren't very different. But if you look at the exploratory outcomes, which they did not report, you would find spinal versus GA. Spinal had much lower incidence of myocardial infarction, pneumonias, acute kidney injuries, and critical care admissions. So spinal was comparatively better for in-hospital stay as compared to GA. So that's something that we have to think of for the outcomes and what was really told in the study. And I think the study wasn't really powered very well because they had much younger patients. They had included patients over 50 years old, patients who could walk at least 10 meters or across a room. They would not take patients who were more frail. There was a huge issue with spinal crossing over to general anesthetic. More than 50% of patients were converted from spinal to GA, but the outcomes weren't processed the same way. And almost two-thirds of the patients who had GA also had nerve blocks. The patients who had spinal actually had lots of sedation as well, to a point that almost 50% patients had ketamine and benzodiazepines on top of spinal. So that model of the study, they thought that their death rate would be about 25%. The death rate's only 15 to 20%. So I think they didn't power the study very well. So I don't think the outcome was as clear as they have shown to be. Okay. Now, that was one part, but this is a study that happened at China. And this was the Raga trial, which is regional versus GA. And they were pretty much trying to find out as well if GA could reduce the incidence of delirium. And this is a very good infographic that they've shown. And they've basically shown that there's not much difference between GA versus regional for patients getting delirium. Same with this study, it had issues. They had younger populations. In Western countries, you had normal age of about 82 to 85 who get hip fractures rather than a younger age. I know for India, it's much, much lesser. They're still 5 to 8 years lesser than that. The issue was their ASA population, the patients, 80% patients are ASA grade 1 or 2. I don't think we find such patients, unfortunately. Then they had patients who were taken care by their relatives because they had a program in which the relatives took care of the patients. So the incidence of delirium was much, much lower. It's actually unheard of incidence of about 6% delirium after hip surgery. Two-thirds, in fact, 73, 74% of patients had combined spinal epidural and they were taken up as a spinal per se. Then instance that they used for delirium was quite flawed. And they also had a small sample size as compared to, they thought they'll have 25% delirium, they only had 6%. So they couldn't power the study very well. And one single center had more than 65%. So I think their outcome, similar to the Regain trial, wasn't exactly that, what GA equals spinal. But I think over the years, various setups have said the same thing, that spinal versus GA may not really be the only thing. There are other things as well. So that brings me to the point, as physicians, what do we want for patients who have anesthesia? So this comes in from a study that was published by the Irish group in 2019, and then a newer study that's come out earlier, late last year, on the QR codes. And they think about what do we want as physicians for patients who come to us. We want less time from admission to surgery. We want good pain management, input from orthogeriatric teams. We would want to make certain that patients able to get some physio within 24 hours of surgery, less incidence of delirium, less pneumonia, hopefully no hypertension intraoperatively, no kidney injury, no heart attacks, and perhaps patient goes off live. Now, the same group that did this asked patients, what is it that you would like? Okay, patients said, you know what, I would really want to make certain that everything goes well. I want to make certain that there are no complications. I have a good quality of life and I go back home where I came from. So I think patient needs are a bit more different as compared to what the physicians want, but they match up together. And I think that's where we have to think of doing studies to really find if there's a difference between GA versus spinal rather than just saying, they're both the same. So this is the second, this is what, so I showed you the other one. So this was brought out from the paper that I've just shown you, this one here. Okay. So what's our role? What do you think is the role of an anesthetist? I think we have to think of pre-op, operation, intra-op, or post-op management. I think this is where we sit at as anesthetists. And pre-op wise, I think we have to assess risk for every patient, optimize if we can, give them good enough pain relief, and if we have geriatricians in our place, get them to have an input into this pathway. We talk a lot about risk assessment. What does that mean? Perhaps why do it? We do it because almost 30% of our patients might have cognitive impairment. They might be ASA 2 or 3, and we have to make certain that if we give them an anesthesia, they're going to come out the other end with not many problems. That's one part. Do we have any tools? I think yes, there are tools. There are national hip fracture scoring, that Nottingham hip fracture scoring that came in from the UK, which is quite comprehensive. It tells you that, you know what, you do these scores. If the score is more than 6, 7, then you're sitting at a point that the patient is going to have more frailty, more issues post-operatively. So at least you score them what it looks like. There are scores which you can see if the patient is going to have cognitive impairment later on. That's a 480 score. It's a acute delirium assessment score that you can do in emergency department. You can speak to the patient, see if they're alert, if they've got issues with attention, there are any fluctuating courses in their mental setup. If that's the case, you would have to make certain they don't give them drugs to make them more delirious. You give them, if you want to give them a spinal, if the patient's appropriate, to give them pure clean spinal without sedation. So give less delirium drugs. The last one is a clinical frailty score, which is now getting a lot of international attention and is being commonly done in most centers who practice hip fracture surgeries. And it's very clear. You actually basically have to ask patient, one, are they able to go out and about when they're not ill or they don't have any issues? One. Second, are they able to shop for themselves? Are they able to dress themselves up? And then you can put them into categories for frailty. A score of 4 or more puts them at a higher risk of having issues post-operatively. And I think this is very clear that you need to do some sort of risk assessment scores. Okay. Future research is required, so mix the scores together so that as the patient comes in, you can put it in the app and you can tell the patient, you know what, you are at a higher risk, you need to be optimized and we have to do more things. Okay, now this is the ongoing controversy. Should we delay the surgery or should we optimize it? And I think if you look at various trials, it says that the longer you wait after 24 to 36 hours, every 24 hours, the mortality goes up by 10%. So we have to make certain that we get the patients in. The trial Hip Attack 1, what they did was they did the surgeries in patient within 6 to 8 hours of their coming to the hospital. And they found there was no difference in myocardial infarction or length of stay, but the patients were able to mobilize much easier. The cognitive impairment was much lower. So this wasn't harmful that you're operating patients as they came through, but it in fact was beneficial to the patients. Okay, we have to basically balance out. If the patient needs optimizing of certain things, we can optimize it and then do them within 24 to 36 hours rather than wait for 2-3 days. Like it's now been found, good 15 to 20% of patients who come to the hospital will have murmurs. So there was this Econof study which they made the anesthetists do echo for patients as they came through, and they found that almost 20% of cases the anesthetists had to change their plans, especially if they know what the issues are, but also suggested that we shouldn't be waiting for a long time to do echoes. They say that, you know, if there is an issue, the patient needs to go through, put in an arterial line, make certain patient doesn't get hypertension, manage them properly, and the patient should be okay. Anemia is the other one. I think there's a lot of talk. What is now suggested, if you've got a cardiovascular disease, keep a HbA of 10, otherwise keep it at 9, and use tranexamic acid. The POISE 3 trial, which was published last year, was very clear that tranexamic acid helps to reduce blood transfusions, because blood transfusions themselves can have issues, as we all know. Okay, and there's a strong evidence that you should be using it in patients to reduce blood loss and reduce transfusion. Okay, delirium wise, I'll speak to you in the next slide. The other bit is antiplatelet drugs. If the patient's on a single drug like aspirin, I think most of us can do a spinal. In fact, the incidence of vertebral hematomas is less than 1 in 10 to 1 in 25,000. And if you put the patient in high D and the patient needs a spinal or would benefit from a spinal, I would go ahead and do it. Perhaps not the same for vitamin K antagonists or direct oral anticoagulants. I think there are clear guidelines from various authorities that you have to wait for thrombin inhibitors or factor 10H, you have to wait for at least 24 hours if the patient's kidneys are okay. I think that's where we're getting at, that if needed, you can do it, but wait for maybe 24 hours to optimize the patient. Okay. But at the end of it, you need a multi-D team working together to make certain that everything gets done. The patient is optimized. You get them up and running for theater as soon as possible. Okay. Right. So I think it is now very clear. There's decently good evidence that you should be operating patients within 48 hours, better uh, outcomes. Okay. Bit about delirium, not the bottle of delirium tremens, but delirium itself. I think almost a quarter of patients who come to the hospital will suffer from cognitive disorders, especially after hip fractures, and it does affect them later. Sorry, give me 1 second, it's not working for me. Okay, it's an unpleasant experience by the family and the patient, and it's been clearly said patients who got lots of delirium tend to have higher chances of mortality. And there are multiple factors. I think this is a good mnemonic. Pinch me. If you have any of these things in a patient, there's a higher chance they'll suffer from delirium. Similarly, you have to recognize delirium. Remember, I talked about the 480 scores. I think if the patient comes in and you do a 4A score, it gives you a clearer idea very quickly within 2 to 3 minutes that the patient might have some delirium on arrival or may suffer later. And if you do anesthetics in them, you have to make certain don't give them longer acting drugs like midazolam, like anticholinergics and deliriants. Manage their pain better and get them into surgery. I think if you look at Canada, this comes from Ontario, and I think they've been very clear that you keep the patient in an environment where you make them eat, you do puzzles, talk to them, move them around, and let them wear their glasses, have enough fluids to keep them well hydrated, well fed, and they feel that the level of delirium is much lower. A bit about pain management. I think preoperatively, it makes sense to do catheters or maybe even single shots, and you can repeat single shots every 6 to 10 hours. That's the QR code on the left was published by the World Federation Society of Anesthetists in August and gives you very good review articles. Review article for nerve blocks and hip fractures. So if they're residents, they can find this there. And it has been shown that we all know that nerve blocks for patients reduces pain, reduces confusion, much lower incidence of respiratory complications, assists patients to move, put them in a position to get a spinal and get them up and running much quicker. Okay. However, there's not even a single block that you can give in which nerves are not spared. So even in FIB, patients might have a bit of pain. So you have to think about giving them Panadol, paracetamol, or non-steroidals if it's appropriate. Okay. Perioperatively, I think we should all top up the catheter before we take it out if the catheter is in, or give them a single shot block even if they're going to get a spinal to put the patient in the position, and if possible, post-operatively maintain with multimodal analgesia. And acute pain rounds are very important. I think it's now mandated that the next day you should probably go and see the patient, and good evidence for incorporating blocks and multimodal analgesia. Okay. Now you might say, what nerve blocks? A femoral nerve block, a fascia iliaca, or a PENG block? I think PENG is a newer one on the horizon, but the evidence that's now getting coming through with time, it shows that all these blocks are pretty much similar, all three of them, and you can use either of them and works quite well. But you have to give other drugs as well to make certain other nerves are also caught on. A bit about orthogeriatrics. I think this is the Association of Anesthetists stands very clearly. They say that an anesthesia should be an integral part of MDM care for hip fractures, and we should be participating in making formal pathways. Okay, and very good evidence for that. And I think what do orthogeriatricians do? They help remobilize the patient, get them up the following morning with the supervision via physiotherapists. They get them doing their regular activities within 4 to 6 days if they've optimized the patient very well, and rehabilitate them once they go home. So I think it's an all-encompassing field with the orthogeriatrics, and if we have such services, we should be actually getting them in. Okay, so what's our role next? That's the intra-op role. I think with the anesthesia sprint audit from UK, it was very clear that as patient becomes more and more hypotensive intraoperatively, less than 80 millimeters, the mortality increases. You would see that the mortality goes up as you look at the left. As the systolic pressure goes down, you would find the mortality increases. And I think we have to really make certain that hypertension's treated very quickly. And it has been shown if you used more than 2.6, 2.7 of heavy bupivacaine, patient gets more hypotension. So that's something that we have to think of. Use less than 2 mils perhaps of intrathecal bupivacaine. And if you think the patient's getting persistent hypertension, think about the 5 H's and 5 T's from the ALS, plus think about bone cement implantation if that's going on. Okay. There's this study that came out, the systematic review and meta-analysis, which showed that there's not much difference if your patient had GA versus spinal. So it's not that the people who get spinal have far worse hypertension as compared to GA, and that's proven through various studies over the past 20 years. Similarly, GA versus spinal, there's not much difference for myocardial infarctions post-operatively. However, I think we still have to talk about how you conduct them. You basically have to avoid hypertension, avoid drugs which might give rise to delirium, and we have to think if the patient really needs sedation with a spinal anesthetic. I think it's very important that we think about it. Not every patient should get sedation with a spinal. If your spinal is good enough, it has been found that the BIS of patients after spinal is as good as patients almost half asleep. So you have to think if the patient's cooperative, don't give any sedation whatsoever. And even with drugs, probably use much lower doses. I started on using 2.6, 2.7 mils. I have now gone down to about 2 mils of bupivacaine, 0.5% heavy. I don't use fentanyl. And over time, I realized our surgeons take about 2 hours sometimes to do hip fracture surgeries, including positioning on table, and patients are perfectly fine post-operatively. So I think we have to think how much we give it. Do we give intrathecal or we just go without it? They talk about if the patient needs a GA, especially if they've come in acutely, you don't know if they are full stomach or not, do definitely put down a tube, but let them breathe spontaneously. It will reduce amount of atelectasis eventually at the end, and you can actually recruit them as needed. And think about doing peripheral nerve blocks. I think we've all been taught peripheral nerve blocks, and they can be done even without an ultrasound. And I have done lots of them when I was training up in India. And even when I go back now in resource restricted settings, I still do them. It does help them position the patient, does reduce the amount of drugs you give them post-operatively, so less delirium. Okay. More often than not, I think we have to standardize what we do for our patients. So it's said very clearly by the various stances that we as anesthetists should have clear standards, and most hospitals should use age-appropriate anesthesia drugs and get patients up and about earlier rather than them being on the bed. Okay, similar stance from the American Academy of Orthopedic Surgeons. Last, a bit about post-op care. I think not all patients can go to HIDE or ICU. We have to think what we can do for our patients. It's a case-to-case discussion is what we look at. Standardize the post-op pathways, discuss with the surgeon what's possible, and take it from there. I think eventually the aim is that we can manage the patients well with appropriate anesthesia techniques, with giving them good pain relief, and rehabilitate them in the wards and get them away home much sooner than delaying it. And I think post-op rounds make a lot of difference. Maybe the following day with acute pain teams or by own cells. I know when we do private, it's not possible, but when I was doing private back in India, I used to ask the surgeon the following day, is the patient okay? Just gives me an idea how I did the previous day, if nothing else. Okay. I don't want to talk a lot about consent, but I think there's lots of issues with cognitive dysfunction. There are lots of issues with comorbidities and what patients want and not want, but it makes sense to stratify patients. Sometimes our relatives want to know, hey, is my patient going to be alive? What's the chances? So I think the National Nottingham Hip Fracture Score is very good. It's freely available online, and you can find the score very quickly and tell them, you can quantify it for the patient that, you know what you're getting done, this is the risk, and this is how you might do post-operatively. Okay. Last but not the least, I think it's a shared decision making. We have to ask the patient, see what they want, and take it from there. And if the surgery is not possible, I think conservative management should be an option. Okay. So pretty much, and coming to my end, I think pre-operative we have to optimize the patient, get the surgery done. It's shown that patients who don't get hip fracture surgery, even if they're ASA 5, 50% of them die. Even if you operated on ASA 4 or 5 patient, that 50% death rate comes down to 25%. So I think it's very important that if possible, the patient is fit, should be operated on, but have enough consent from the family, involve a team, standardize the anesthetic, but personalize for every patient, and have a case-by-case discussion post-operatively. Okay? So pretty much standardized hip care pathways by conclusion, have multidisciplinary approach, improve time to surgery, do post-op rounds, and I think if you do have Department of Ortho Geriatrics, maybe have constant meetings with them and orthopods to see how we can continuously do audit in bigger hospitals to keep it going. And I think overall, just doing an anesthesia is important, spinal or GA, but we are a very small cog in the trauma, in the patient comorbidities, in the surgery. So I think we can't really make a clear decision for what goes on. Okay, so I leave you with the question, what would you do, a spinal or a GA? That's pretty much it from my side. Thank you. That's the references. And if you want to ask me any questions, happy to say that.
Yeah. Very good presentation, Dr. Preet Anand Singh.
Thank you.
It's always a debate since many years, people whether to go for GA or spinal or a regional. Excellent presentation because you have shown many references. There is a evidence-based, and of course, it is a discretion of a consultant to decide, and there are various factors. So what we do is there are a lot of audience or many consultant pieces are there. Once we finish the second topic, we'll have end of the two topics. We have a questionnaire or doubts about the audience. Be there on the line. And now we'll go for the second speaker, Dr. Priyanka Bansal, for our topic on cervical plexus block. Very few centers, I believe, this practice being done, and she is going to enlighten us what are the indications for superficial and deep plexus, cervical plexus, and present era. What are the surgeries where you can use these techniques, and she is going to tell us, elaborate us. And now the topic is, and now I am welcoming the Priyanka Bansal to go ahead about your topic.
Thank you, sir. And first, I would say Niku Vanka. I just googled that how to say namaskar in Telugu, and if it is if it is wrong, do correct me. Okay. I hope I just do justice to the topic, and especially thankful to Dr. Reddy for giving me this beautiful chance to present on this.
Actually, I insisted Priyanka to do this topic only. So, thank you.
Thank you, sir. Okay. The things which we are going to discuss today is the relevant anatomy of the cervical plexus, the landmark and the PNS guided technique, ultrasound guided blocks, of course, this is the trend today, and indications as well as the complications. Just to shorten anatomy, it is an important plexus of nerves that supplies the head and neck. It is located anteromedial to levator scapulae and the middle scalene muscles, as well as deep to the sternocleidomastoid. It is situated on the anterior rami of the cervical C1, C2, C3, and C4. Each participating ramus divides into ascending and descending branches. And so for these branches join together, the ascending branch of C2, for example, join with the descending of C1, and descending of C2 joins with the ascending of C3. In this way, 3 loops are formed, which we call as ansa cervicalis. In short, it divides into superficial branches and the deep branches. The superficial branches are cutaneous or the sensory branches, and the deep branches are the motor branches that innervate the muscles of the neck. The cutaneous branches will supply the skin of the neck, superior lateral thoracic wall, shoulder, as well as the scalp between the auricle and the external occipital protuberance. The superficial branches being the lesser occipital, greater auricular, transverse cervical, and supraclavicular. The lesser occipital nerve supplies the skin of the neck and the scalp, as well as the posterior superior region to the auricle. The great auricular nerve, which is derived from C2, C3, supplies the skin over and sheath surrounding the parotid gland here, the mastoid process, and posterior inferior to the auricle, as well as the skin from the angle of the mandible to the mastoid process. Transverse cervical, which runs anteromedially between the platysma and the sternocleidomastoid, it supplies the skin covering the anterior triangle. The supraclavicular nerve is important in the context that it supplies the skin over the clavicle, and we block cervical plexus and clavicular surgeries along the interscalene. It's a good option for high-risk patients. This is just a recap of which we just read. Now coming on to the motor branches. The ansa cervicalis, as has been described before, is formed. We'll cover more details later, as well as the phrenic nerve, which is derived from C3, C4, C5, the dorsal scapular nerve, as well as the long thoracic nerve. The ansa cervicalis has superior and inferior roots. It innervates the infrahyoid muscles, sternothyroid, sternohyoid, omohyoid, but not the thyroid, which is derived exclusively from the motor branch of C1, as well as there is another muscle, that is the genohyoid, which is also supplied by C1. The phrenic nerve has motor, sensory, sympathetic branches. It is motor to the diaphragm, sensory to the central part of the diaphragm, the mediastinum pleura and the pericardium. I just wish we could be, the students listening to me, we could be in person and share this. Anyway, this is the recap of what I just covered. And in relation to the surrounding structures, it is situated on the anterior surface of upper four cervical vertebra and rests on the levator, angular scapula, and the scalenus medius. I'm covering this because this will form the landmark of our block later on. Now coming on to the blocks. The cervical plexus block is superficial, intermediate, and deep. Brief history. Although it was started, the story started in 1912, but it was in 1975 that Winnie first revisited an important approach we'll discuss later. This is for deep cervical plexus block. In 1989, the concept of superficial cervical, exactly what it is, came into, and in 2003, which was later modified in 2004, in his study in Pandit JJ, first revolutionized the intermediate cervical plexus block to cover the fascia. And it is also important because this is which will, it is important for covering the blocks. First is the superficial cervical fascia, also is the subcutaneous tissue. Now the superficial layer of the deep cervical fascia. This is the part. Why is this important? This is the difference between the superficial block and the intermediate block. Another, this is the middle layer, the strap muscles, and finally the deep layer of the deep cervical fascia, this blue one. This is the perivertebral fascia, and this is the which is punctured during the deep cervical plexus block. And these are the blocks, a more clear anatomy. That superficial block is just the subcutaneous block. Intermediate, we cover the investing fascia, and for the deep, we have to puncture this prevertebral fascia. The indications of these blocks are the superficial surgery on the neck, as well as like lymph node dissection, excision of the thyroglossal and the brachial cleft cyst. In my tenure, I've seen this lymph node dissection quite frequently being blocked for this cervical plexus. Superficial and intermediate are the ones which we use quite frequently. Another is the vascular access surgeries. For thyroid surgeries, yes, they're indicated. For carotid endarterectomy, the story started from here, and the clavicle fracture repair, as well as the ear surgeries. The contraindications are the general, which we have also for the spinal as well. The patient refusal, local infection, previous surgery on the neck, radiation therapy, contralateral phrenic nerve palsy, and significant pulmonary compromise. Now the landmarks. This line which we will draw now from the mastoid process to the Schizans tubercle, that is the C6 transverse process just below the cricoid cartilage. This line we have to remember. We'll need it later on also, as well as the posterior border of the sternocleidomastoid. A line is drawn joining the mastoid process to this tubercle, and 2 centimeter caudal to the mastoid process is C2, subsequently 4 centimeters C3, and 6 is C4. More clearly, it is depicted here. The block needle is inserted at an angle perpendicular to the skin. Mind you, it is perpendicular to the skin. It is slight caudal orientation, which is really important to prevent inadvertent needle insertion towards the cervical spinal cord. Sorry. Needle is advanced until transverse process is contacted. It should not be advanced beyond 2.5 centimeter. It has to be kept in mind. At this point, needle is withdrawn. Once the transverse process is hit, needle has to be withdrawn 1 to 2 mm and 4 cc of local anesthetic, approximately 10, total of 15 ml, 4 cc of whatever we can give per level. Now the superficial cervical plexus is quite simple. It is just a subcutaneous infiltration along the posterior border of the sternocleidomastoid, which is also the Erb's point. The landmark is, it is drawn here beautifully. The line joining the mastoid process to the C6. Needle is inserted at the midpoint of this line. The branches of the superficial cervical plexus emerge from behind the posterior border of the sternocleidomastoid, and approximately at this time, subcutaneous infiltration is there. Fan technique is followed. Redirection along all the directions. I'll show here more clearly. See, it has to be redirected superiorly as well as inferiorly. 5, a total of 10 ml of drug, and the drug which we choose is 0.2% bupivacaine or 0.25% bupivacaine. Now, clinical pearl. If the subcutaneous midline injection from the thyroid cartilage to the suprasternal notch, from here till here it is made, it will block branches crossing from the opposite side as well. Now the complications are the infection. It is low risk if we follow all the strict aseptic technique. The chances are of course less. Hematoma, phrenic nerve blockade. I'll show the why is the chances of phrenic nerve blockade in subsequent images. Local anesthetic toxicity, we have to calculate the dose quite frequently. Then there is chances of nerve injury, as well as spinal anesthesia can be induced if too much of the drug injection is used. Proceeding towards the ultrasound guided cervical blocks. It was in 2003 that the story started, and in this study by J.J. Pandit, he quoted, the study was done in cadavers. He quoted that 2 types of blocks, that is superficial as well as deep blocks, were given in certain number of cadavers. But for superficial, what was the problem? He said that the investing fascia was exposed and then the drug was given. And subsequently in his conclusion, he mentioned that the drug which was given superficial block also reaches the deep block, which is why this study was objected later, a year later, in the very next year by Telford. And he said the classical superficial cervical plexus walk is the one which is described by Murphy and Scott. It is just a subcutaneous infiltration. But the technique which was previously described by J.J. Pandit is also something which is the drug is given below the investing layer, and it was later on known as the intermediate cervical plexus block. And it is revolutionized because 90% of our surgeries are accomplished by these 2 blocks only and avoiding the complications of the deep blocks. This is the image which I had covered previously. Now a little more in detail. The superficial cervical plexus block consists of subcutaneous infiltration, this yellow part. The intermediate is a subfacial block in which the investing layer has to be punctured. This part is also punctured. And then the drug is deposited below the posterior border of the sternocleidomastoid. And the deep cervical plexus block is the deepest injection in which the transverse process is hit after we puncture the prevertebral layer. For sonoanotomy, the subcutaneous is landmark guided. It is more successfully given landmark guided technique because it is just a subcutaneous infiltration. So sonoanotomy is for the intermediate cervical plexus block. Deep or lateral to the posterior border of the sternocleidomastoid, a small collection of hypoechoic nodules. This is the plexus. A small collection of hypoechoic nodules between the investing layer of the deep cervical fascia, this block is given, as well as between the prevertebral layer. A high frequency probe is taken and it is placed on the lateral border of the sternocleidomastoid. Visualization of the plexus is not a necessity. Administration of 10 ml of drug deep to the sternocleidomastoid provides a reliable block. This quite a disturbance here actually. And the drug is deposited behind this posterior. This is the sternocleidomastoid muscle. After puncturing the investing layer, the drug is deposited along this border. We have to be very careful that the phrenic nerve is not punctured here. Now in this study, this was a study in which the D block was introduced first by Vinny by a lateral approach. He said that the prevertebral fascia invests all the prevertebral muscles, the longus coli, the longus capitis, as well as the scalenus anterior muscle. The cervical plexus is beautifully hugged by the investing fascia and the prevertebral fascia, and this forms the basis of this important block. Extremely simple technique if done correctly, and hence was born the deep cervical plexus block. From his study, I've taken this image because I want to emphasize the fact that the direction of the needle was not so clear in any of the image I googled. The direction is very important. It has to be side corded or a little, you can say perpendicular, but it has, or horizontal, but it should never be safe. Like there are high chances that we hit the vertebral artery and numerous other complications, which I'll be covering later on in my technique. See, the injection to the vertebral artery, the epidural space or the subarachnoid space becomes possible, and hence it's quite dangerous. This block is actually, this deep cervical plexus block is a deep double-edged sword, because if placed correctly, the drug will ascend superiorly as well as inferiorly along the plexus, and numerous surgeries can be possible in high-risk patients, which may not be otherwise possible, high-risk under GA. Now, later on, a number of landmarks were covered for the deep cervical plexus block. For example, in Usai's study, this is another important study, the longus capitis was used as a landmark. In another study, posterior cervical space was used as a landmark. Pericentesis, this study gained quite an importance. And in this scapulae, the levator of the scapulae was used as a landmark. Here, this yellow one is the levator scapulae, and between the sternocleidomastoid levator scapulae, the drug was deposited. I'll show it more clearly here. This is ultrasound imaging study by Pericentesis. He said we have to confirm the flow of the vertebral artery, and then the injected is made between the SCM and the LS. This is after the injection of the drug. He showed images in his study. Now this literature is sparse for obvious reason, because most of the surgeries can be accomplished with either the superficial and intermediate cervical blocks without going into the complexity as well as its associated complications of the deep block. Now the three approaches have been described in a study by Singh. First approach is it's a very simple view. In this approach, the drug is deposited behind the carotid sheath. Here, the drug is deposited behind the carotid sheath. Now another important carotid artery, which is of course full of risks. The second approach, which is defined as the groove, interscalene groove between the scalenus anterior, scalenus medius, this interscalene groove, the drug is deposited. This is approach 2. And the approach 3, which is thumbs up technique, is somewhat more newer one. C4 level is marked, and how it is marked, I'll show. The transducer is placed laterally. It has already been shown how to mark the C4 landmarks superficially. In this, the transducer is placed laterally and it is moved posteriorly till the transverse process of C4. How to identify the transverse process of C4 is by thumbs up technique, exclusively defined in this study, where the thumb points towards the carotid artery. Once this thumbs up or the C4 transverse process is visible, then the drug is deposited. Now, this transverse process will, of course, we will incur this transverse process if the needle is introduced from the lateral side. It is best to use from the medial side. Hence, along the long axis under direct vision, once the tip of the needle is in close proximity of the posterior tubercle, aspiration is done. After all, RAP we follow, and then 10 to 15 ml of the local anesthetic is injected. Now, this is a really important, actually, the crux, I would say. If we have the superficial and intermediate block performed successfully and the results are good, it is best, till we can avoid the deep block, it is the best, because the complications are very dangerous and there are high chances. And also, Pandit JJ in his study, very carefully, he has mentioned that it is best avoided this block. He was the one, he did a number of studies on this block. He said the complications, the risks are so much that it can lead to respiratory problems, the paralysis, the vertebral artery puncture, the local anesthetic toxicity. This is the same study, and best avoided. And also he said, which is important, is the D block is more than twice as likely to yield a serious life-threatening complication as a result of this block placement. And there are 5 times more likely to fail. Why? Because whatever regional we know is a failure is, of course, it is converted into G, and we consider it as general norm that this is the failure of the block. Nonetheless, after so much discussion, there is another friend that Carling and Simmons is stated explicitly that the safest cervical block has not yet been established. Now, covering my last slide, as far as the bilateral cervical plexus blocks are concerned, it is the superficial block which can be given bilaterally. Intermediate is avoided because of the chances of the phrenic nerve involvement, and deep block is not recommended at all. Bilateral deep block is not recommended at all. Finally, you don't have to be great to start, but you have to start to be great. Thank you so much.
Satyanarayana sir. వెంకట్ మీరు క్వశ్చన్స్ తీసేసుకోండి, సారు వినట్లేదు. వెంకట్
Unmute.
So both are excellent presentations. Venkat,
Sir.
chat box lo questions ఏమైనా ఉన్నాయా?
No, sir, nothing.
There are no questions there, Rama. I think I just checked. I was just looking at the chat to see.
We have senior faculty with us. Dr. Deepraj Singh is here, very experienced. Sir, would you like to add something?
Deepraj, sir.
If not, can I ask a question, Dr. Priyanka, please?
Yes,
That's
sir.
okay. Dr.
Yes,
Priyanka, I was
sir.
just wondering, so for carotid endarterectomy, what would be your final say? What block would you do?
So carotid endarterectomy, it is best to perform superficial combined with intermediate, considering in view the risk associated with the deep cervical plexus block.
Okay. Thank you. So when you do such cases with block, do you also use some sedation?
So actually, ideally sedation is recommended, but we have to keep the airway intact. So sedation of that degree we avoid usually, especially in this head and neck surgeries, the airway needs to be intact.
Okay, yes, no, that's what I wanted to, because I know there are lots of postgraduate students. Just wanted to ask you what you would do.
Definitely, the airway needs to be intact, and sedation, like 1 ml midazolam, of course, won't do anything, but that is also patient oriented. Best sedation is avoided.
Lovely. Thank you for that. I think there's a question again for you.
There is one
Says
question.
for ear surgeries, which type of cervical block is preferred for ear surgery? Dr. Sadika Fatima asks, for ear surgery, which type of cervical block is preferred?
See, that is beautiful. It's a subcutaneous block. That is the superficial block would go for it. And of course, that is the pinna surgeries or the auricle, the mandibular surgeries or the superficial mastoid. That surgeries can be given for superficial cervical. Excellent. It would work excellent.
Yes, I think that answers. Thank you. What I've realized over the years is we are doing superficial cervical plexus blocks also for putting in central venous lines in patients who are actually patients who are awake, and they work just one single block and that works quite well.
Yes,
thank you.
Right.
This is Dr. Shamsundar, and the question is again for you, Dr. Priyanka.
Yes, sir.
So, a nice presentation. The thing is, like, it's continuous with the ear surgeries. So many times, like where you want exactly location and what quantity of the drug need to be given. And sometimes what we observe is we are not getting adequate analgesia, even if you give under ultrasound guided superficial cervical plexus block. Do you want any, like you want to give a little bit more cephalad can be better, or any particular change of rather than standard technique?
No, not very specific, but if it is given like some injection 5 ml is given superiorly, 5 ml is given inferiorly, we can alter a little more amount of drug can be given. Otherwise, this superficial block works well for the ear surgeries, and the drug like 5 or 6 ml can be given. It has to be given in a proper way at that Erb's point behind the posterior border. I think even ultrasound is not given, is not required if we give the block properly, 5 ml superiorly, 5 ml inferiorly, and 5 ml in that.
How many cases it was adequate? How many times you want?
See, definitely the failure is there, but the superficial is usually combined with intermediate. We would prefer to combine it with intermediate. There are definitely failure rates are there. Like
yeah,
you can
that's what
say,
I want to say that. Yeah, here surgeries
failure rates are there, sir.
Yes. Thank you.
So can I suggest Dr. Shamasundar, because
Yes, sir. Yes, sir. You are welcome, sir. Yeah.
So I will tell you. So we also do these blocks. What we've now realized is if you just give it at one spot, it doesn't work very well. As the fascia starts opening up, you actually get the needle further in, so the fascia opens up, the deep cervical fascia that opens up, and that gives a much better block. Because a lot of times the thing is that you can see if you quickly want to do it, I think you have to advance your needle further in so that there's a full complete spread rather than just a single side that you give. And that gives rise to, because I used to have a failure of good 10 to 15%. As I've started to involve the fascia a bit more, the failure rate has gone to less than 2 to 3%, and the patient wakes up with absolutely clear head, and we don't have to use a lot of sedation about it.
Yeah, true, sir. What we try to do is a little bit, giving more drug or more of little cephalad can be helpful to cover and to reduce the failure rates.
Yes, absolutely.
Sir, Dr. Shamsundar.
Yes, sir.
Sir, I too observed there's a very good response, and the block is very good, deep cervical block. If we tilt towards the cephalad and to the other side of the opposite side and tilt like this, suppose this is the head, you just and keep it opposite side, the success rate is very high.
Probably, sir. Probably, I don't like in our situation. The moment we give back, we immediately will put the position.
You have to watch for all the problems and complications. The flat spread of the drug is more, and the block success rate of the block is more.
Yeah, variable. Not like other blocks.
Okay.
Yeah, I can have an access now. Good evening once again. Is a good presentation, Dr. Bansal.
Thank you, sir.
What is your regular practice for deep cervical plexus block you are doing for, what are the type of cases you are doing?
So, not very frequently for the deep, we don't go very frequently, but yeah, definitely for the, like if the thyroid is quite large, then we can prefer. But deep we usually avoid because it's associated. It's actually a double-edged sword I've mentioned previously. If it has
since our PG days and even today, we all know that bilateral deep cervical, it's absolutely not to be practiced because of known complications. But superficial, yes, most of the post-thyroid surgery, what still I am doing is a post-operative analgesia after thyroidectomy, superficial bilateral cervical plexus block. And even securing an IJV also, it is recommended superficial cervical blocks, unilateral, and some other all submandibular area, lateral part of any sebaceous cyst or a small lymph node excision. It's a very good, wonderful block, superficial cervical plexus block one can practice even without ultrasound. I think for deep cervical, I think you require an ultrasound guided. But superficial, being in a very superficial, not necessary to have a ultrasound guided. So a very good presentation, and now the Dr. Preet Anand Singh, is a very good, important topic you had. It's a debatable topic. And we all know, since by default we have been doing since many years, and particularly in this private setup and peripheral centers, everybody knows that. Of course, we are also practicing a geriatric age group hip fracture. There is no question of going for general anesthesia. For age old, we are practicing. Maybe because of fear, the geriatric age group, subjecting general anesthesia and all related complications. But still, what is your impression? Still, the GA is a choice of technique in some selected patients. What do you feel that, Preet Anand, which are the group of patients GA has to be there, GA technique of anesthesia, GA, and which type of patient, group of patient you recommend?
So I think from experience, what you're saying is quite correct. Most patients get spinal, but with time realize that patients who are cardiovascularly unstable, that's one group. The other one is that patients who can't lie flat. If you can't lie flat, can't be cooperative, I think GA is something which is quite mandatory. Patients who got really bad cardiovascular disease, that if you do a spinal, then would be a problem. But in those patients also, we started doing continuous spinal, and that works pretty much same as well. But pretty much patient who's not cooperative, who's got other contraindications to putting a needle in their back on double anticoagulants, or patient on who cannot wait for a surgery, cardiovascularly unstable, these are patients who would normally do GA. But with the coming literature, I think in private setup, obviously you want to do spinal and get out of the way. GA shouldn't do, but if you have resources, then do a standard GA. And it has been shown that doing GA versus spinal, as long as there's no hypertension, as long as you keep everything stable, there's not much of a difference, to be honest. But what I do suggest, even if you do a GA, what I do suggest, please do a single shot nerve block, either a femoral plus a lateral femoral cutaneous nerve or a fascia iliaca. Definitely should do, even if the patient does put in local infiltration, single shot nerve blocks are quite a thing. If there's no ultrasound, just do fascia iliaca block. That works equally well. 30 mils of 0.3% or 0.2% bupivacaine.
Yeah, particularly patient with pre-existing LV dysfunction, maybe ejection fraction less than 40 and all, then there is a debate, and there is a question of whether go for regional spinal particularly or grade epidural. For that also, as you mentioned about, for positioning technical problem and all, you need to have in a regional nerve blocks so that the patient can have a good position and tolerance and all that is practiced. What I personally feel is, as soon as the patient admits in the orthopedic unit with a fracture, your role has to be there from the day one onwards, because the pain factor, even if you take up surgery for even after 48 to 72 hours, the pain which is, you are supposed to take care of the pain, because that is the main culprit, the pain and inflammation. Most of the perioperative cardiac complications is a pain factor. We all know that. So your role has to be there from the, as soon as the patient admits in the hospital, in the orthopedic unit. So you have a role to have this very intracapsular blocks and the nerve blocks, whichever are mentioned. So is it that practice you are doing in your center as soon as the patient admits before you take up surgery?
Yes, absolutely. So we have an orthogeriatric team that's in the hospital, and the nursing staff in accident emergency. We get activated as soon as the hip fracture patient comes in. We do have pathways as well for hip fracture patients, and operative, non-operative. As soon as patients admitted, we are all in the same WhatsApp group, the hospital WhatsApp one, and patient gets seen on the first day to see how they can be optimized. We've just done a QI survey that got published in BMJ Open last year. Our waiting time was 67 to 72 hours for operating. They've now gone on to 45, 46 hours after putting in quality improvement initiatives. So I think it's very important to see the patients as soon as they come in very correctly. We give them a block on within 6 hours of admission. We want to make certain that pain relief is there. We make certain that the consent is there and the patient's with us all the time.
And finally, from my side, what is your DVT prophylaxis for hip fracture patients you are following there? DVT prophylaxis?
Absolutely nothing.
If the patient is not taken up for surgery for more than 1 week, even then?
So if the patient's not, then they get classified to see what most patients. I think we've got more than 50% patients who are on aspirin. Actually, we did a retrospective audit to find out more than 50 to 70% patients are on aspirin. If they are going to be immobile for a long period of time, then they get put on a bit of subcut heparin as a prophylactic dose.
Yeah.
But most patients do not get DVD prophylaxis. I think we're moving away from that sort of a practice in the country.
Yeah. Good.
But it's a case by case discussion. But most patients do not get DVD prophylaxis because we found that the incidence is very low actually in our setup. But I agree that there should be some DVD prophylaxis, and I've seen patients getting thrombi very, very quickly after hip fracture. It is thrombogenic, the surgery at the fracture site.
So
Yeah.
from my side, it's two speakers are very good, excellent. So congratulations for your excellent presentation of both speakers. Thank you very much.
Yeah, Dr. Anand.
Anyone, please
Yes,
they
sir.
can interact with the
Yeah,
speaker.
yeah, Dr. Anand,
There is
further to
one-
add the discussion, this is Dr. Shyam. So, see, I
Yeah,
want a clinical scenario where you have difficult intubation for
Uh-huh.
the hip surgery. So, like a setup where you want to have having full range of gadgets. What do you prefer? Or like general Indian setup where we don't have much fiber optic bronchoscopy, video laryngoscopy may not be available. In the scenarios, which one would you like to suggest? This is just to add a practical point to the practitioners as well as students.
So if it is difficult airway that you're suspecting in a patient, what we normally prefer is that you try doing a spinal with a regional technique as a first stop. Now we have to make certain that the patient doesn't even have a difficult spinal. That's when the problem starts happening. If the patient has difficult spinal as well, then it gets more difficult.
Difficult
Does it answer-
intubation, I said. I said difficult intubation. Patient is having anticipated difficult intubation. So,
for
you
them,
have advanced setup and low compromise setup, which any difference or just you go ahead with the regional first, or you go directly face the difficult intubation first as middle of the surgery.
No. Regional anesthesia is what I would be looking at for such patients. For patients who is anticipated difficult airway, you try give them spinal, speak to the surgeon that this is the best you can do, this is the best we'll do, and give them a regional block as well to give them complete analgesia that includes femoral and lateral cutaneous nerve of thigh. To make certain that, because when they cut laterally, sometimes the spinal doesn't work very well. You need to have the lateral cutaneous nerve of thigh, which can be done right with either fascia iliaca block or separately with ultrasound. I think that's a question that Dr. Sadika asked.
Yeah, thank you.
I would not intubate a patient who's got anticipated difficult intubation as a first step for a hip fracture patient. I would much rather trial a regional technique.
Correct. Yeah, that's correct management.
Thank you. Any other questions?
If there are no questions, Venkateshwara?
Yeah, she answered even Sadika question also, sir. She asked
Okay.
that,
A bit loud, volume.
One student asked that what kind of
That was covered. Yes, that was covered.
So no other further questions, sir, in the chat box. Yeah, no questions. So Preet Anand sir and Priyanka Bansali. Thank you, sir.
Bansal.
Thank you for your
Bansal.
Yeah, sorry.
Sir, well, this webinar is also very well attended. Nearly 60 plus 65, 70, nearly touching.
Don't count, Shyam. Don't count the attendance. The thing is, we want the content.
True.
Never think about the attendance.
Very good.
No, it's obviously I'm just want to
See,
remind
whoever gets benefit, they will get benefit. If they don't want to attend, we are not going to bring them, forcefully. So we will do our work, and few people will get benefited.
Yeah, true, sir.
Can I just say my vote of thanks to Dr. Rama Reddy? Thank you very much. I saw you after 16, 17 years. I don't think many of you know. I met Ram after we worked together in the UK, and I came to TACON in Hyderabad in November. And by chance, I saw this smiling face. I said, "Hey, kahan pe? So, and thank you for giving me this opportunity.
Thank you.
And best wishes. It was really amazing to see what you do, and thank you very much for inviting me. Best
Thank you,
wishes. And
Preet. Thank you.
I met Dr. Satyanarayan also. We had a picture together. I didn't
Yes,
share
yes,
it. Thank you.
yes, yes. Thank you, Priyanka, as well.
Thank you so much, sir. Thank you. I don't have any pictures to share. I'm totally new to this platform, but best wishes for your future lectures too.
Thank you. Thank you. So, Venkat,
Okay, someone's asked. Just give me 1 second. If somebody
Yeah, yeah.
asked, let me ask, can you suggest any video links for nerve blocks? Can you look at the regional anesthesia pain medicine YouTube links by Jeff Gadsden, please? North Carolina, Duke. So not just Duke, so not just Nisora, but Duke by Jeff Gadsden. There are good videos about superficial and deep cervical plexus blocks, and it'll work. Thank you. Sorry
I'm
to
also, sir.
interrupt, Ram.
No, it's okay. I hope that answered all the questions. Venkat, can we conclude? Venkat, can we conclude?
Yes, sir. We can conclude, sir.
Yeah.
Yes, sir. Preetana, sir, very much thank you for your kind time sparing and your elaborated speak on spinal versus general anesthesia and hip surgery. Thank you once again, sir. And Priyanka Bansali madam also, you have thrown a good light on cervical plexus block, which are the indications and non-indications, benefits of superficial plexus block and deep cervical block, where we should not apply the deep cervical block. It's very informative, madam, for the PhD students and practitioners
Yes,
also.
sir.
Very much thank you, madam, for your kind sparing of
Thank
time
you, sir.
and sharing your knowledge with our students. And we are so much thank you, madam, for your participation.
Lovely.
Thank you, sir.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye.
Bye-bye.
Thank you.
Thank you all.